Hello, this is Dr. Gary Condon from Drexel University College of Medicine and the Coastal Eye Institute in Sarasota, Florida. Welcome to this educational activity on identifying and managing primary open-angle glaucoma.
The following audio is part of a certified educational activity titled Identifying and Managing Glaucoma, a deep dive into pharmacotherapy and patient-centered care. Access the entire activity and complete the post-test at www.peerview.com/RDA. Downloadable infographics and other materials are also available.
Glaucoma is really a group of diseases that have one common final endpoint. That endpoint is the damage to the optic nerve, and this is both functional and structural in the sense that these patients develop nerve fiber layer damage, optic disc excavation, also referred to as cupping, and later on, this is associated with visual field loss. If untreated and advanced, it can have a major impact on the patient's ability to function visually throughout their life. One of the biggest dilemmas in taking care of patients with glaucoma is the fact that they are generally asymptomatic. In fact, it's only when there is really severe visual loss that these patients notice that they have a particular disease. And that is really the biggest problem in identifying patients who have glaucoma and need treatment. There are many different types of glaucoma. Categories include open-angle glaucoma, where the anterior chamber angle is anatomically open, and closed-angle glaucoma, where there is clearly apposition between the iris and the trabecular meshwork. The major issue we deal with in our clinical practice day-to-day in this country is, in fact, primary open-angle glaucoma, and this is the condition where there's nerve damage with no discernible reason or cause for that damage. Now, intraocular pressure is a term that's often mentioned when we talk about glaucoma. That's due to its strong association with the condition historically, and it really is the only element of the disease that we can actually treat or target for treatment. Yet elevated intraocular pressure is not necessary for the definition or diagnosis, and it is not necessary to see elevated intraocular pressure in patients for diagnosis of glaucoma. This is a highly complex and rather confusing area in considering this particular disease. What is high intraocular pressure? Historically, we think of high intraocular pressure as the intraocular pressures that are greater than 21 millimeters of mercury. And as I've said, these are not universally present in all patients with open-angle glaucoma. So in fact, if we look at what percentage of patients actually have elevated intraocular pressure with the diagnosis of glaucoma, depending on what population we look at, we can see as many as 30 to 80% of patients as having intraocular pressures less than 21. And these pressures can commonly be in the mid to upper teens. Here in the United States, roughly 20 to 30% of patients diagnosed with glaucoma have in fact these normal pressures. Now, the converse, elevated intraocular pressure, can often be present without glaucoma damage. And this is a scenario we term ocular hypertension. So we can see ocular hypertension or elevated intraocular pressure, if you will, existing in patients without open-angle glaucoma who in fact may never develop open-angle glaucoma. And this is one of the things that creates a tremendous dilemma as to who we should treat as a glaucoma patient. There are many studies that look at what factors could convert a glaucoma suspect into somebody who has full-blown glaucoma. We use the term glaucoma suspect often interchangeably with ocular hypertensive. One such study was the Ocular Hypertensive treatment trial. It was a 5-year randomized study looking at the effect of lowering intraocular pressure versus monitoring patients with elevated intraocular pressure. Now, these are patients with intraocular pressures between 24 and 32 who had not been treated with pressure-lowering treatment. So half of them were then monitored, and the other half were treated with pressure-lowering therapy and followed over a period of 5 years. And what this study found was that in patients who were left untreated, there was about a 10% likelihood that they went on to develop glaucoma. And this is opposed to those that were treated with intraocular pressure lowering, who had only about a 5% likelihood of going on to develop glaucoma. But most importantly, what this study did was it identified certain risk factors in the patients who have elevated intraocular pressure that predispose them to developing glaucoma. And these factors are older age, higher intraocular pressure, greater cup-to-disc ratio, thin corneal thickness, and a greater pattern deviation on their visual field test. And by pattern deviation, that's a lumpier or less smooth visual field contour, so to speak. Interestingly, family history is a relatively weak risk factor for the development of open-angle glaucoma, unless a patient has a direct sibling or parent who has gone blind from the disease. So in view of these risk factors that have been identified, one of the things that has come to our aid in looking at these glaucoma suspect patients are things called glaucoma risk calculators. These are essentially online programs that you can plug your individual patient's risk factor information into, including the things I mentioned, as well as their intraocular pressure. And these devices will provide you for the likelihood that your glaucoma suspect patient might go on to develop real glaucoma in the next 5 years. Again, these risk factors include the patient's age, in that the older the patient, the more likely they are to develop disease, the intraocular pressure, which is the greatest risk factor for the development of glaucoma, the corneal thickness, which is really an index, if you will, of how we interpret the intraocular pressure. Patients with thinner corneas will typically display lower intraocular pressures, and so we can tend to underestimate the intraocular pressure in patients with thin corneas, thereby elevating their risk. The vertical cup to disc ratio is really the assessment of the optic nerve appearance in these patients. And then the pattern, a standard deviation, as I mentioned, is just an irregularity in their visual field pattern that would suggest that it's not entirely normal. So who do we treat as a glaucoma suspect, and why is it important? It's important because it can have a major impact on that patient's life. They get labeled with a chronic disease if we decide to treat them. They're often burdened then with medical treatment that's ongoing for the rest of their life. So we want to treat those patients with a high risk of developing disease, and we want to avoid unnecessarily treating patients who have a low risk. It's important, however, to point out that with either of these options, there is absolutely required ongoing monitoring and involving the patient directly in understanding the importance of that ongoing monitoring, and that just the fact that you're not actually treating them doesn't mean that they can just disappear without returning for ongoing follow-up. And that's one of the problems, as I alluded to earlier, is a patient who's a glaucoma suspect or an ocular hypertensive with some risk factors for glaucoma is somebody who you may not be treating, somebody who's asymptomatic, and therefore somebody who's very likely to not follow up with you in the long term. So what sorts of tools and things do we use to identify risk factors and the existence of disease? Intraocular pressure measurements, as I mentioned, the most important risk factor. The corneal thickness, the assessment of the optic nerve, both by photographs as well as on clinical exam. Visual field testing, what we refer to as perimetry. And then more fancy technical tests that we've come to use in recent decades that involve actually measuring the optic nerve tissue, the retinal ganglion cell layers, and more recently, the ganglion cell layers in the macula. These are all tools to create baseline measurements and to also monitor the patient going forward. A normal optical coherence tomogram, as well as a normal visual field examination, can be very reassuring in evaluating a patient with elevated intraocular pressure. And with otherwise relatively low risk factor profile is somebody that we could certainly monitor, like you see in this image right here. On the other hand, it is the importance of the ongoing monitoring where we will identify subtle changes that the patient will not be aware of that would then indicate a need for us to change our direction and start therapy in a given patient. And in this image here, we see a series of OCT evaluations on the left side. And in the upper part of that left side, I've drawn a circle around an area where the optic nerve or nerve fiber layer thickness measurements have begun to change. And while this might not even produce an early visual field loss, it is something that triggers our suspicion that this patient is in need of treatment. And in this particular case, there was a very subtle early visual field change, as you see on the right-hand side, in the supraonasal area associated with this. The value of the OCT testing in patients we're following as glaucoma suspects or ocular hypertensives is that we're more likely to see a change in the optic nerve or nerve fiber layer before we can detect a change in the patient's visual field. And it's this early detection and initiation of therapy that I feel is extremely important in maintaining this patient's visual function throughout their lifetime. Now, in terms of the management of glaucoma, the goal of medical therapy in these patients is to reduce the patient's risk of progressive damage by adequately lowering the intraocular pressure in both high pressure primary open-angle glaucoma as well as the low or normal pressure open-angle glaucoma. We can reduce the production of aqueous utilizing beta blockers, alpha agonists, and carbonic anhydrase inhibitors. We can enhance trabecular outflow, historically with cholinergic drugs like pilocarpine, which have predominantly gone by the wayside due to their side effects. And indeed, there are some newer agents I'm going to talk about in that category that enhance trabecular outflow that are just coming on stream now. On the other hand, more recently, in the 1990s, we have the most efficacious agent on a singular basis, which are the prostaglandins. And these work by enhancing uveoscleral outflow, which we term the non-conventional mechanism of having aqueous leave the eye. Prostaglandins are classically considered first-line therapy since the late 1990s, really. We have bimatoprost, latanoprost, and travoprost as the typical big three. And these are the most efficacious agents, as I mentioned, with the ability to lower the intraocular pressure by up to 30% commonly. They have the advantage of once-daily dosing and are generally well tolerated. There's a preservative-free option available as well, more recently, called tafluprost. These medications have set a very high bar for any new agent that's coming on stream, as you'll see shortly. So assuming we have a nice response to a prostaglandin agent as first-line therapy in lowering a patient's intraocular pressure, how do we know if it's adequate? How do we know if the patient's therapy is really working? And this is a very difficult question to answer in many cases because of how much time it takes to determine whether or not there's change occurring in either the patient's optic nerve or visual field. So we need periodic visual field retesting to compare the results from previous examinations, as we also need periodic examinations of the patient's optic nerve, their nerve fiber layer, and whatnot, again, looking for evidence of stability. So the goal of treatment should be adequate intraocular pressure lowering to allow stabilization of the visual field and the nerve fiber anatomy. In a patient such as this, where we see progressive visual field change over time, we identify a situation where we're clearly not adequately lowering that patient's intraocular pressure enough. Now, this depicts a thought process we might consider when we're trying to arrive at what would be a reasonable intraocular pressure range for a given patient. And all this image is designed to do is to have you consider what your pressure goal might be depending on certain factors related to that patient. So on the left side of the screen, if we have a patient with early disease who had a relatively high pressure to start with, and there's barely or no detectable glaucoma damage, we might think that a relatively modest pressure reduction of 20% or somewhere in the upper teens or even low 20s might be reasonable to follow that patient over time. On the other hand, as we go to the right, if we see a patient who has a relatively low untreated intraocular pressure, they're going to need a lower intraocular pressure to make a difference to the stress factors related to their optic nerve. If a patient appears to demonstrate visual field change over a short period of time, we consider them to have relatively rapid progression, and in those patients, we're going to want lower intraocular pressure ranges than in some of the ones I mentioned earlier. What about life expectancy? If we have a patient who has terminal cancer, we're certainly not going to overburden them with medication to lower their intraocular pressure excessively when we really feel that their eye and their optic nerve, so to speak, is going to outlast them anyway. So there are numerous factors that we put into our mind, so to speak, or consider when we're looking at what sort of zone of intraocular pressure we'd be happy with in monitoring that patient. We might aim for that, but at the same time, we're still going to continue to rigorously monitor that patient going forward, looking for evidence of change, which would again change our treatment plan or escalate our treatment plan. So the message here is that it's really important to individualize your goal of therapy or your pressure range, so to speak, for a given patient, taking in the patient's entire makeup, where they started from, whether they're progressing rapidly, how old they are, their life expectancy, and whatnot. Now, roughly 50% of patients who are being treated for glaucoma need more than one medication to achieve that target pressure range. And things like disease severity, comorbidities like asthma, other medications that include antihypertensives and whatnot, like beta blockers already being taken orally, potential tolerability issues, patients who have high incidence of allergic conditions and whatnot, will all determine what additional therapy we might go to for second-line treatment, given, say, that the patient is already tolerating a prostaglandin, but we're looking for a lower intraocular pressure. So side effect profile, ease and frequency of administration are all things we take into consideration when we go from that first medication or first-line therapy to further downstream. Now, historically, beta blockers since the 1970s had been really the mainstay of therapy before prostaglandins came along in the 1990s. Beta blockers decrease aqueous humor production. The classic one is timolol, 0.5%. One of the problems with beta blockers, as they've been studied in conjunction with prostaglandins, is that they tend to add little efficacy to a patient's intraocular pressure lowering if they're already on a prostaglandin. And in fact, in the United States, there are no combination prostaglandin beta blocker agents available. There are in other parts of the world, but not here in the U.S. As far as the side effects go, beta blockers do have a greater systemic side effect concern or profile than the prostaglandins, predominantly with exacerbation of COPD and bronchospasm. But it's common to see patients, elderly patients particularly, develop fatigue, depression, and impotence when they're taking even a topical beta blocker. And this can go unrecognized as a medication by some of the primary care physicians or internists unless the patient is, or we're communicating with the primary care physician adequately to indicate that the patient is taking a topical beta blocker. Carbonic anhydrase inhibitors suppress aqueous humor production. The ones that are available are dorzolamide and brinzolamide. These, unfortunately, ideally are dosed 3 times daily, which makes them somewhat more inconvenient. They can be used singularly in monotherapy, and there are available fixed combination therapies that put these agents together with either timolol or brimonidine, as I'll talk about in a moment. The most common complaint with topical carbonic anhydrase inhibitors, particularly dorzolamide, is a bitter aftertaste and burning or stinging that's really due to some of the pH issues with these agents. The alpha-2 adrenergic agonists make up another broad category, and in this one we have brimonidine currently in a number of different strengths. This agent both decreases aqueous humor production as well as improving uveoscleral outflow. This again can be monotherapy agent, second-line therapy, and is available in fixed combination with a beta blocker, as well as more recently a fixed combination with brinzolamide. Again, the TID dosing ideally makes this one less appealing from the convenience standpoint. Fixed combination therapy is currently available in the U.S., including combinations of timolol and dorzolamide, timolol and brimonidine, and more recently brinzolamide and brimonidine. Now, these can offer greater potential for improved efficacy, pressure lowering, as well as improved adherence by reducing the number of drops required for therapy or the number of bottles the patient has to carry around or keep track of, so to speak, required for their therapy. An example of a more recent fixed combination agent is that of brinzolamide and brimonidine together. And here's the intraocular pressure lowering effect when this agent was studied compared to its individual components. So the blue and the red bars represent individual components of either the brinzolamide or brimonidine, and the green bar would represent putting them both together in the same bottle, and you can see there's a dramatically improved intraocular pressure lowering effect with both agents together at all time points from 8 a.m. to 5 p.m. So this looks like a very efficacious medication that can certainly add tremendously to a patient's intraocular pressure lowering therapy. More recently, and in fact just in 2018, we've had the release for the first time in a long time 2 new agents available to us in medical therapy for patients with open-angle glaucoma. And this really is a pretty significant deal since the last time we had any new class of drug happen was back in 1996. So it's taken that long to find anything that will come close to the prostaglandin agents in terms of their efficacy. And the first one of these is latanoprostene Bunod, approved in 2018, as I mentioned, as well as Notarsadil. And on the horizon or in the pipeline, we have the combination of Notarsadil and latanoprost. Let's talk a little bit about these. So nitric oxide is the element in latanoprostene Bunod that makes it different than latanoprost itself. It's a combination molecule, if you will. It's a single molecule that has nitric oxide attached to the prostaglandin analog, which in this case is latanoprost. Nitric oxide is an intracellular signaling molecule, and it's produced endogenously in all of us. It activates the cyclic GMP pathway and results in relaxation of smooth muscle and relaxation of trabecular meshwork cells. And so this can increase the aqueous outflow through our conventional trabecular meshwork pathway. So when we attach it to latanoprostene in the form of latanoprostene bunod, we have an agent that affects both aqueous outflow pathways, the trabecular outflow pathway, that is, as well as the uveoscleral outflow pathway, which is the pathway the latanoprost uses. So when the agent enters the eye, it is cleaved into these two singular components that have a dual mechanism of action. And clinical studies have shown that the latanoprostene bunod agent lowered the intraocular pressure more than latanoprost alone by an average of about 1 to 1.5 millimeters. The most common side effects with this agent include stinging as well as redness or conjunctival hyperemia. So this is a new agent that's really just come into our hands, and we're gaining experience with it as the months go by. As I said, it was only released this year. Now, the Notarsadil is another molecule that's new on the market, and this has a dual mechanism of action. It inhibits two things. It inhibits Rho kinase, which increases trabecular outflow, and it also inhibits the norepinephrine transporter, or NET, which may reduce aqueous production. So this has a dual mechanism of action as well. And in clinical trials, Notarsadil was shown to be about equivalent to timolol used twice daily in patients with pressures below 25. So Notarsadil is a once-daily dosed drug, as is latanoprostene bunod, again, putting them right up there with favorable dosing profile agents. Now, when we look at Notarsadil versus latanoprost, we see that latanoprost outperformed Notarsadil in the clinical comparison by a small amount. And this comes back to the idea of how incredibly efficacious these prostaglandin agents have been since their release in 1996. So what's on the horizon with Notarsadil, not just as a singular agent, but in fixed combination with latanoprost, and adding latanoprost to Notarsadil, we see a improved intraocular pressure lowering efficacy compared to each of the two agents alone. So we have these novel components with multi-complementary modes of action, convenient once-daily dosing. Again, ocular redness is the main issue. They really rely on the efficacy of a prostaglandin as their backbone, so to speak, to make them or allow them to get over that high bar set by prostaglandins over the last 2 decades. Now, adequate treatment of glaucoma requires a high level of adherence and compliance to therapy by any individual being treated. And this is probably the singular greatest challenge when we manage patients with glaucoma. As I said, these patients are asymptomatic. Many of the medications they use have symptoms or some adverse effect or have something that doesn't really make them enthusiastic about using it. And so without any symptoms, the motivation to use a medication, as you can imagine, might be quite low for a lot of patients, all of us really. And then if you add other elements like adverse effects and cost, then you can see why the challenge of compliance or adherence to therapy is probably the biggest one we face. And studies looked at this issue in a number of ways and found nearly 45% of patients in one of these studies took fewer than 75% of their prescribed doses. As I said, factors that affect adherence, convenience of using medications. Obviously, a once daily medication might be better adhered to than a medication that's required to be taken 3 times daily. Patients have issues with cost. Some of these medications, particularly the new agents, are not available generically and they are expensive. The patients may not believe that they have a condition that needs treatment. They have no symptoms. Why am I taking this drop? Why is this costing me money? Why should I have these burning eyes or red eyes when I see just fine, doctor? So having the patient understand the risk of not taking their medications and understanding their disease is really paramount in treating these patients in the long term. I think it's important to establish a solid relationship with your patient. I think from my perspective, I'm not about lecturing to a patient. I want to know their real life experience. I'll ask them open-ended questions like, how are you doing with your drops? What's your batting average with your drops? How often might you get them in there? Even more open-ended than that, how are you feeling about your glaucoma? But things like, you're taking your drops, right? Or you better be taking these drops, or what do you mean you're not taking your drops? Things like that sort of present a confrontational relationship, I think, are non-productive. So open communication with patients, being supportive with patients, never giving up, throwing your hands up in the air sort of thing is really absolutely critical in maintaining a relationship with a patient that's going to, A, keep them coming back to see you, and B, be realistic and truthful with you about what they're able to do with medications and what they're not able to do. So I think aside from developing that relationship with your patients and having them understand that you're on their side, working to reduce the burden of their medications as much as possible with fixed combination agents, as I mentioned, proper eye drop installation is very important. Just simply observing a patient instill an eye drop can be very telling. And as I said and emphasized, listening and not lecturing the patient is going to improve your relationship and hopefully their adherence and understanding of their therapy. Selective laser trabeculoplasty, I consider as a very conservative measure as well. In fact, laser trabeculoplasty has been shown to be as effective as latanoprost once daily in clinical studies. So I think of selective laser trabeculoplasty literally as a category of another medication. It may reduce the medication burden for patients who aren't able to use multi-dose or maintain adherence or compliance with multi-dose therapy drugs, and it's a very safe and innocuous therapy. So in terms of glaucoma, early detection is critical to preserve visual function and patient quality of life. Patients with early glaucoma often remain undiagnosed until it progresses to advanced stages when central vision is affected. The asymptomatic nature of glaucoma is just a very, very difficult problem in terms of identifying it. And while there are about 3 million patients in the United States with glaucoma that know it, there's about that many again who actually have glaucoma and who are unaware of it. There's no standard guideline for optimal target pressure. Therapy must be individualized based on the patient's profile, patient's risk profile. Medication or surgery can be an effective first-line option depending on patient preferences. By surgery, I mean laser therapy. Fixed combinations can offer greater efficacy as well as enhanced compliance. And again, I can't overemphasize engaging with patients is essential, as the adherence is the key to their treatment success. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/RDA. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.